Good afternoon, ICU team. My name is Ramesh. I'm a transplant infectious disease physician, and thank you, Rodeo, for inviting me to talk about invasive fungal infection, yeast and mold infections in ICU. But predominantly, the message of the talk is going to be concentrating on yeast, particularly Candida, because most of the mold infections are related to transplant-related stuff. Rarely do we have issues with mold in a non-transplant setting. So there is still a lot of confusion, controversies in terms of diagnosis, management, and candidal infections. So we'll try to understand that the best we can at this point of time. All right, so the objectives, we're going to talk about epidemiology, risk factors of invasive fungal infection, some investigative modalities that are available, and then how do we manage them in an ICU setting, more focused on ICU at this point of time. So if you look at invasive candidiasis, generally, candidemias, generally over the past several decades, there has been at least a 300% increase in candidal infections, bloodstream infections, and this was at least 10 plus years ago, and currently it is still the same. It's still the same. There's been a profound increase in invasive infections. There is also increased incidence of fatal invasive mycosis in United States, at least 0.4 per 100,000, and somewhere in between 0.2 to 0.4 when it comes for aspergillosis. So there is increased incidence. So when it comes to invasive fungal infections, because we are a transplant center, I'm not talking about transplant-related infection at this point, but I just want to point that out, that there is definitely increasing incidence of mold infections compared to candidal infection when we come to organ transplants, both in the solid organ side and in the hematopoietic stem cells side. Invasive aspergillosis is 19% and 43% at this point of time. Okay, great. Thanks. No, that's fine. So if you look at a national databases of surveillance databases of candidemias, in the last decade or so, Candida was the 4th common nosocomial bloodstream infection in the United States, with mortality approaching 40%, particularly in Lyme-related Candidemia. So it was 4th. The first ones being Quagga-negative Staph, Staph aureus, and Enterococcus. But in this current decade, or in the recent past decade, it has become 3rd at this point of time. So it is still a profound disease. Generally, this is generally not as necessarily ICU, generally. And then there are more and more newer species of Candida that is actually causing trouble, causing invasive candidal infections. So we have to pay attention to some of them. At this point, not relevant completely. Albicans and the rest of the species are the major ones, which we'll come to it. So if you look at the type of species that we are commonly isolating, the predominant species is still Candida albicans. Because we have we use significant prophylaxis in bone marrow transplants and certain organ transplants and stuff like that, we actually see breakthrough Candida glabrata with resistance because of so there is increase in Candida species with higher incidence of fluconazole resistance. Candida krusei, intrinsic resistance to fluconazole and stuff, and Candida tropicalis has lower or higher resistance levels to fluconazole. Parapsilosis exquisitely sensitive to azoles, and there are other species we'll talk about at the time. So what about Candida when it comes to ICU? What do we know? It is common. It is the 2nd in rank when it comes to ICU related. I'm talking about invasive candidiasis when it comes to bloodstream infections and stuff like that, both in North America and in the European Union, and it's definitely deadly. The attributable mortality is 49% in certain studies, and it's expensive. We'll look at some raw numbers in a minute. And in ICU, we need definitely time-critical decision making, because the longer we delay treatment of invasive candidiasis, there is increase in mortality, which we'll show data on. So what about the different forms of invasive candidiasis that we see in ICU? We may see candidemia in the absence of deep-seated infections from lines. Or we may see candidemia associated with deep-seated candidiasis as metastatic foci from the candida, and then Candida, deep-seated Candidiasis without detectable Candida, which is probably a pretty significant amount as well. As you can see, it's about at least 30+%. So in this ICU study, for example, in UK, there are 6 UK hospitals prospective study. There is 3 episodes of Candidemia per 100,000 bed days, and 45% were in the ICU. So ICU is a major risk factor for Candidemia. Candida albicans was the predominant one in that time. This was published about 10 years ago. And majority of isolates were susceptible to fluconazole, and outcomes were definitely improved with removal of catheter. We'll talk about it down the road. What about in the United States? This study is called NEMIS. It's basically an epidemiological study of mycosis, so national epidemiological mycosis study in, say, sepsis. So there is 6 surgical intensive care units in the United States, and the overall rate was 9.8 per 1,000 admissions, 48% Candida albicans, mortality of was 41% with Candida infections when we compared without. So it's profound, it's significant. So what all does ICU-related Candida infection results in? Clearly there's an enormous burden. There is excessive mortality rate of 10 to 49%, depends on different studies, different populations. There is excessive length of stay as well, approximately 3 days to 30 days, excessive cost, and the average cost of Candidemia, according to, say, for example, these 2 reports, it's at least 40,000. So it is pretty expensive. So we talked about it. So average length of stay is 22 days. Mortality is slightly different thing in the European side. Mortality is also pretty high. Major problems are it's not straightforward. It's not easy to diagnose because Candida doesn't grow that well compared to, say, Staph aureus, for example, even though we do identify periodically. And then we can, so what we need to do is we modify our protocol. We come up with certain higher risk groups. Can we do empiric management versus preemptive management strategies when it comes to ICU, because time is critical when it comes to ICU. And obviously we have to be aware about the local flora in terms of what is the resistance rates. In our transplant population, we are much more careful about what we choose and stuff like that because of intrinsic higher resistance rates. Okay, so generally, not ICU, generally what are the risk factors for invasive candidiasis? So obviously critical illness and a long-term ICU stay is a crucial thing. Any abdominal surgery, because Candida resides predominantly in the second portion of duodenum and predominantly in the gut and stuff like that. So any abdominal surgery that involves multiple laparotomies or leakage is going to promote invasive candidiasis. What about necrotizing pancreatitis similarly, and then your transplants, immunosuppressed hosts, that kind of stuff. Then some secondary risk factors, obviously, selection of candidal colonization, such as broad spectrum use of antibiotics, presence of Lyme, presence of TPN, and then hemodialysis, and then of course known documented colonization. So those are risk factors. What about in the non-neutropenic patients in the ICU, for example? We can see that indwelling catheter carries the one of the highest relative risk of 5.4, then prior surgery, TPN, acute renal failure. So this is in the ICU particularly. So what about in the transplant population? The risk factors hold good. In addition, we have additional problems of immune suppression. So that is the only additional difference at this point of time. So, so in the ICU, the major risk factors are prior antibiotic use, central venous catheters, TPN, major abdominal surgery within the past week. So steroids, immunosuppression, and increased length of stay. The rate of infections rises rapidly after about 7 to 10 days of ICU stay. So based on this, we come up with risk scores, risk categories, which we will talk about down the road. Not all of them have very predictive values significantly, but at least we have something better than nothing. So that is the message. All right. What about non-candidal species albicans in non-neutropenic ICU patients, the non-transplant group? So of which the major risk factor for that is age, recent GI surgery again, and more importantly, the prior use of antifungal agents empirically, fluconazole. So obviously, so that's why we want to be reasonable about limiting use of antifungals empirically if possible. So what happens generally when there are risk factors? There is antibiotics are used routinely in this population. There is selection of Candida with colonization, and there is either skin or gut mucosal damage. and with associated with instrumentation or GI surgery, we get invasive candidal infection. So, associated with gut inflammation or line-related stuff, there is Candidemia, and then it seeds everywhere. It seeds the bone. It just like staph, it forms nice matrix, glycocalyx-like matrix, and it seeds everywhere, forms biofilms everywhere, and so it lingers longer in the artificial stuff, and it has a potential to metastasize significantly. So obviously we can have metastatic lesions in the kidney, in the spleen, in the liver, eye, endophthalmitis, and patients go blind if you don't catch them early, lungs, bones, all those places. So that's what we look for in our ICU patients when we evaluate them when we get a consent for Candida. So this is in the organ transplant side. The mortality is still pretty damn high. You know, it's overall it's 24% mortality just for Candidiasis. Okay. So what about in the organ transplant side? Even though that's not the aim of the talk, you can see the prevalence of candidal infection is very high with liver. Why? Because the second portion of duodenum is being involved and stuff like that. Certainly we see rarely in other transplants too, unusually, but this is the major thing that we see: liver, kidney, or liver, pancreas, liver stuff. All right. So what about invasive mold infection? I'll talk briefly about mold infections because I don't have a lot of time related to, and that is a major topic by in itself. But here and there we'll touch upon it periodically. So we know that ICU stay and then loss of barrier immunity and decreasing immunity promotes candidiasis. But now on top of that, when we add, in addition to the loss of barrier and neutrophilic function for additionally, there is additional cellular immune dysfunction in the organ transplant side and neutrophilic dysfunction in bone marrow side. Additionally, along with cellular immune, you get invasive mold infection, of which the most common one being aspergillus. So when it comes to aspergillosis in solid organ transplant, if you look at large databases or studies, lung clearly stands out because aspergillus is a colonizer in the setting, and we also use a higher degree of immune suppression when it comes to lung transplants. And small bowel carries a slight risk, but clearly lung takes the cake. And we also see it obviously in our neutropenic host, and this is mortality is very high in different populations, of which mortality is higher with bone marrow transplants and stuff like that. And then rarely we see mortality in invasive candidiasis in the advanced age, which we rarely see now at this point of time. And what about zygomycosis, another mold infection? So when do you see them? Same risk factors, but who are on voriconazole prophylaxis, then we can have a breakthrough with zygomycosis because voriconazole does not cover this. Otherwise, pretty much similar risk factors such as aspergillus. So basically, T cell suppression or neutropenia and additional. So, for example, in countries such as India, invasive zygomycosis is seen in uncontrolled diabetes. It's a tropical country. Zygomycosis is like everywhere in the environment. So we see that quite frequently as necrotizing fasciitis. We are not talking about chronic zygo. We're talking about acute zygo infections, not necessarily sinusitis and rhinocerebral mucormycosis, that kind of stuff. And then certainly there are other modes, but unfortunately we won't go too much on it this time. So what about the clinical diagnosis? So clinical manifestation of invasive candidiasis is unfortunately very non-specific. So all you may develop is just fever. And it looks like sepsis-like syndrome, and you don't identify any bacteria. You did cultures, sites different, nothing comes out. And then you may see a macular nodular rash, which I'll show you a picture, and you will think it might be drug allergies, but it's actually invasive candidiasis with candidemias. And then suddenly a careful ophthalmic evaluation might show. Sometimes eye doctors actually come to ICU for other reasons, and they check it out and say, hey, you know what, should we have checked for Candida? And then it turns out that your Candida T2 is positive in that setting, and then you want to treat aggressively at this point in time. So this one looks like a small nodules. That's how it looks like, but it can be painful. That's the key, is it can be. So if you see painful nodules and stuff like that, you have to look for invasive candidiasis. I mean, it could be other bacteria too. In my bone marrow transplants, this could be anything. It could be Candida, it could be Staph, it could be E. coli, it could be anything. It could be anything. So unfortunately, what we do in bone marrow is if we see anything, we biopsy in bone marrow. Whereas in ICU, non-neutropenic other hosts, we do blood culture. We may think about it. We may think about looking for disseminated Candidiasis. So what about laboratory diagnosis? We don't have good tools at this point of time, despite better blood cultures. At this still, it's only about 50% positive in several autopsy-proven invasive Candidiasis. So it's not very sensitive yet. So half is coin toss. Half the time we miss it. Having said that, regular blood cultures are good enough. We do not need fungal blood cultures to make. It only improves the sensitivity of the blood culture by probably 3 to 5%. When do you order fungal blood cultures? You order fungal blood cultures when you are suspecting invasive mold infection. Number one, invasive mold infections are uncommonly diagnosed through blood cultures because they are not, you don't see them in the blood. But for some reason, you can suspect histoplasma, for example, or fusarium. Then you may want to order fungal blood culture. Otherwise, you don't have to waste your time ordering fungal blood cultures because it takes an extra effort and extra things and delays certain things in the lab. You are better off ordering regular blood cultures at this point of time. Obviously, molecular methods such as PNFH. What is PNFH? It's basically a hybridization technique on the blood culture. If the blood culture is positive, you find it early by a molecular technique and it hybridizes, so you'll identify early. So it's no different. The sensitivity is no different than this one. So we don't have this one. And certainly we have PCRs in the blood that are coming up. Several PCRs. This one we do one of them. T2 is a PCR-based methodology. And then it's a serologic methodology, 1,3-beta-D-glucan. We'll talk about it in a little bit. And obviously, if you have a tissue-invasive disease, you want to biopsy it. Except for maybe lung transplant, where we see occasionally, even there it's still occasionally, we see invasive Candidiasis, not necessarily pneumonia, but we see them as pleural effusions and empyema and stuff like that. Candida in the lung, when we see, it's pretty much a colonizer. So it's an indicator. You just have to be looking out for what else is going on. Candida, this one. Lung transplant, slightly different story. Slightly different story because here and there we actually see invasive Candidiasis directly. I'm not talking about bloodstream and seeding the lungs. I'm talking about direct infection. So except for lung transplant, which occasionally we pay attention, most of the time, for all practical purposes, Candida in the lungs is an indicator for being watchful, not to treat at this point of time. So what are the rapid diagnostics tests? Beta-D-glucan, we know. What does it do? Beta-D-glucan tests for an antigen on the cell wall surface of fungi. And pretty much most fungi carry that, including Candida aspergillosis. But unfortunately, there's a lot of false positive and a lot of false negative. So that is one of the reasons why we took it out of the system, because since we introduced it, it didn't help us, it only confused us. Only time it was very useful was if it is the negative predictive value was much higher. So then the test was negative at times 2. You could potentially say you don't have invasive candidal infection if you're checking for that. Other reason we used to do it is for the test was negative times 1 or 2 if you're suspecting PCP, lung infections. PCP lung infection, it is a good surrogate tool to say. So the negative predictive value is good. But when it's positive, it does not correlate with disease of both Candida or any fungal disease. The problem is false positive rates are quite high, because it can be cellulose dialysis membranes, IVIG infusions, other concurrent infections, cross-reactivities, all kinds of stuff. So it's not good. Mannan is being done only in select centers. It's another antigen-based test, just like beta-D-glucan. Another cell wall component, but predominantly it's more done in certain centers. It's no different than beta-D-glucan when it comes to it. So we did not advocate that. What about nucleic acid direct PCR? That is what we are moving towards. Moving towards at this point of time. So we are going directly into bloodstream PCR-based testing, and the T2 is slightly different. What the T2 candidal test is, you take your blood directly, you amplify the gene of Candida. It's a pan-candidal genes primer that amplifies it, and then you have specific Candida, Candida albicans, Candida glabrata, so 5 different Candida species. specific hybridization targeting, and that's used using a magnetic target. It's a nano target, and so whatever changes that happens in a desktop MRI is how you detect. So it's pretty darn good. Once again, it is good with negative predictive value. So where is it useful? It's useful only in the setting of blood. If you have a rip-roaring Candida peritonitis without any bloodstream infection, you will have a negative T2. You'll have a negative T2. So if you, so it's very important to understand that the T2 is only for bloodstream infections. If you are strongly suspecting tissue disease, your T2 without fungemia, T2 can be negative. So falsely negative at that point of time. So so that's what it's designed for. So when we go to T2, these are the organisms that we see: Candida albicans, Candida glabrata, Cruziae, Parapsilosis, and Tropicalis, because these are the most common organisms and stuff like that. So one of these days, one of our patients in ICU was Candida. Thank God we did concurrent blood cultures, so it was Candida positive on the blood cultures, and it looked like albicans. It looked like albicans, but the T2 is negative. So how do you explain the disparity? It was Lusitania. It was Lusitania, because the T2 will be negative. So we have to understand at this point of time, the T2 capabilities are being enhanced down the road, but at this point of time, these are the only organisms that this one. Rarely, those are very rare. So I don't want you to say that, oh, the T2 is negative, but I'm still suspecting Candidemia because unusual. No, that is rare. That is rare. These are the common organisms. So T2 is pretty darn good. So as you can see, this is major centers, major national studies, multi-center studies. Specificity is pretty good. So the negative predictive value of a T2 test is approaching very high 90s, very high 90s. So if the T2 test is negative, you can pretty much say that you don't have invasive Candida in the blood, at this point of time. Sensitivity obviously is still slightly lower. These are other PCR methodologies, and you can see regular cultures, beta-D-glucan, everything is sort of iffy. So you have moved away from that when you're going straight to T2 at this point of time. So how do you manage Candida? Who to treat, when to treat? Obviously, if it is my high-risk neutropenic host and they are asymptomatic, because they will develop mucositis and mucosal barrier loss, and Candida can transmigrate in that setting. So we automatically do prophylactic strategy. So we prophylact. So high risk neutropenic host with chemotherapy or hematopoietic stem cell transplant, we automatically do prophylaxis. In obviously certain lung transplants and certain liver transplants, because of a certain higher risk, we tend to do that. But predominantly in liver transplants, because particularly when the gut is cut. Because when you do Roux-en-Y, liver transplant with not duct-to-duct anastomosis of biliary duct, when you do Roux-en-Y, we automatically do prophylaxis for a certain length of time. At this point, Otherwise, when do you do? What sort of management would you do? You do preemptive strategy. Basically, high-risk asymptomatic patient in ICU with the biomarker of positive culture, you caught them early enough, and you are trying to catch them. So you're checking for it because you have a risk and you're worried about something, and before they actually manifested with any end organ disease, and that is preemptive strategy. Or you do empirical because they develop fever, and then you decided because you can't wait, you do the T2, you do the blood cultures, and you ordered the antifungal therapy. So empiric management. So those are the strategies that we adopt when it comes to intensive care units. So who do we treat? Is Candida bloodstream infection ever a colonizer at this point of time? Never. So for all practical purposes, everybody has to be treated. Whether they are symptomatic, asymptomatic, 100% of them have to be treated. Every single blood culture patient can be relevant, and because it can seed. So there's nothing called contaminant. Rarely, yes, very rarely, people have rarely identified and forgot to treat, and they gotten away with it, but you cannot. There are 3 infections that you cannot not treat in the blood. Those 3 infections are Staph Candida, Enterococcus. You have to treat it. You have to treat it no matter what. And obviously, you like to find the source and try to eliminate source such as lines, that kind of stuff. That's important. And do not forget to check the eyes. So generally, nobody knows exactly when to check the eyes. Okay, as soon as you identify fungemia, do you check the eyes, or do you wait a week and check the eyes? Nobody knows. So what the ophthalmology people are kind enough is they come and check them early, and they come back in a week and check them if they are still in the ICU or somewhere. So they do it twice. to make sure there is no endophthalmitis. Because the reason why, so what is the definition of candidal endophthalmitis is it involves vitreous. It involves vitreous. So if it is chorioretinitis, because it's seeding, like a metastatic seeding chorioretinitis, you can do your antifungal because blood cultures are there. Blood supply is there, so you'll deliver enough. Vitreous, no blood supply. No significant blood supply. You have to do vitrectomy with intravitreal injection of appropriate antifungal agent. So that is why it's important to identify. That is why the eye doctors are useful. Otherwise, you're no different. You are going to treat them long enough. Usually you treat candida infection for at least, say, 3 weeks, for example, or longer based on if we are suspecting endovascular source of metastatic seeding. But it's important to identify eyes. Why? Because you need, otherwise people will go blind. People go blind because you are suboptimally treating a vitreal involvement, so endophthalmitis.
What if the Candida grew in 2 different places? Will it look at the eye?
No. If the Candida grew in 2 different places, it just tells you colonizer. You have to have other risk factors, which we'll talk about. You have to have other risk factors. So that's why we employ what is called as the Candida score. We're trying to enhance which people, because otherwise what will happen is we are checking everybody for everything and stuff like that, and that'll be too bad. We don't have that luxury of getting eye consults on every damn ICU patient. Unfortunately, because ours is a very large ICU center, and the eye doctors will go nuts. So we just can't do it. We just can't. So we have to be reasonable about it. So we'll try to employ something a little bit better. You have to cut that damn out of it. So what about catheterization? Absolutely must. So there is enough data to show without catheter removal, 82% had persistent infection, for example, in an earlier study. Short-term duration of fungemia after removal of catheter to 2.6 days from 5.6 days. Reduced mortality when they removed catheter, and particularly parapsilosis loves artificial stuff. Parapsilosis, so very strong link to catheters, so you have to remove catheters. There's no excuse. We have to do it the best we can. Sometimes it's difficult, but we push constantly. What about Candiduria? This is a major question that is asked, other than lung colonization. It's a major question that's asked both in the floors and in the ICU. So what does Candiduria indicate to us? Candiduria, even in the kidney transplantation, even in our kidney transplantations, Candida just indicates colonization. It rarely indicates true infection. Rarely indicates. But having said that, when you see Candida that is significant, pure culture, you want to know, is there any upper tract fungal disease such as this one. So you may consider imaging if it's persistent on the upper tract, because they may be asymptomatic, but you want to know if there's upper tract issues. So occasionally we do an ultrasound of the kidney to see if there's a fungal ball or anything going on in the kidney region. Otherwise, your goal all the time is to not to treat. As much as possible, try not to treat if they're asymptomatic. Let's say you're outpatient, you have pure culture of Candida and they are symptomatic, such as severe burning, that kind of stuff. Yep, you do have to treat cystitis, because Candida can rarely cause cystitis, so you end up treating that at that point of time. But for practical purposes, no. So this is still an unusual problem, but frequently colonized. What do? You exchange catheters. The important answer is you try to remove catheters. So please consider imaging appropriately. But when do you treat? When do you definitely will treat is if you have known candidal colonization in the urologic system and you're messing with the urologic system with manipulation, you want to do some short-term course. You won't be able to eliminate the Candida necessarily, but you want to treat it at the time, because Candida, just like gram-negative bacteria, will form sepsis because you're messing with it and will go to the bloodstream and cause trouble. Certainly in neutropenic patients, which similarly we tend to do if they are colonized and stuff like that. Okay. What about, can we wait for positive blood cultures or a positive T2, and then now we have advantage of T2, but let's assume we didn't. Can we wait for blood culture results in Candidemia and stuff like that? The longer you wait, the worse off it is in the ICU setting. And the longer you wait, the worse off it is. And what is worse off? So let's see. So in this retrospective analysis, the delay of empiric treatment of Candidemia till after blood cultures turn positive resulted in higher mortality, which I'll show diagrams. And the start of antifungal therapy greater than 12 hours after drawing a blood culture had a adjusted odds ratio of 2.09 for a risk of mortality. So it's profound. It is profound. So the longer you wait to treat, this study only used fluconazole, the longer you wait to treat, the mortality increases drastically. Day 1, day 2, day 3. You suspect it here, and you decide to wait for blood cultures, because at the time we didn't have those advantages. So now that is why you use the thing wisely. So obviously, a lot of our patients may be colonized because they are in the ICU long enough, because we are a tertiary referral center. So when they are colonized long enough and stuff like that, so do we treat everybody empirically, everybody at this one? So you have to have certain risk factors or risk groups before we say, okay, in this population maybe, even in ICU, can we do something better, is the question. So we'll get to that. I thought it was next slide, so obviously. So the problem is we don't have definite tools, and ICUs are difficult and not necessarily readily available. A delay in diagnosis will result in increased mortality, and so in patients with suspected candidal infection, and we have scorings for that, treatment may need to be initiated on basis of that individual patient factors before a definitive diagnosis made. So what are all the different scoring systems that are available? There are plenty of scoring systems available. This is the older Candidal score, of which the current Candidemia rule, which is mostly advocated, including our own center. If you look at our antimicrobial stewardship website, this is what we advocate, and stuff like that. So, which carry the higher weightage: antibiotics within the past 30 days, central venous catheter, admitted from a nursing home, or a total TPN. Unfortunately, this carries higher weightage. A lot of patients in our ICU, unfortunately. And then mechanical ventilation and stuff like this is 1 point. Lung as a presumed source of substitute, you subtract 2 points, because you rarely have Candidemia in the lungs, Candida in the problem, and then causing lung infection, or rarely to 0. So you actually subtract this one. So you can achieve higher risk here in this criteria. You don't see abdominal surgery here, but in the previous criteria and stuff like that, abdominal surgeries were involved as well as major and minor risk factors. So because abdominal surgery carries a higher risk. So if you look at difference, sensitivity, specificity, or predictive score, particularly the negative predictive score, it seems to be pretty darn good in most of these scores. But the sensitivity is pretty poor. The positive predictive value is very poor, so it's no good. So we still don't have a very good tool. But if you use these tools, and if it is you don't have it, you are not on TPN, you don't have antibiotics like this, none of this criteria, you can pretty much say, despite colonization, you can pretty much say the negative predictive value is there. I don't want to push further. I'm looking for something else at this point in time. So it's a guideline. It's an adjunct guideline. It's not fantastic, but you can use it at your advantage on the right setting, using the negative predictive reason, not for the positive reason. So what about different trials? Several drugs have been studied, both high-dose fluconazole, low-dose fluconazole, the anidulafungin, caspofungin, and voriconazole. They all done pretty well. They've all done very well. But with the latest guidelines, when it comes to ICU, we are suspecting invasive candidiasis. The general recommendation is to start anidulafungin in our center. In other centers, they use caspofungin or microfungin. We start echinocandin, anidulafungin, empirically, pending the T2, and then make a decision. And if identify, and currently you do a blood culture. The blood culture shows Candida albicans or a fluconazole sensitive Candida. You go back, you move down to fluconazole. And a minimum amount of fluconazole is at least 400 milligrams per day, minimum, adjusted for renal status. Renal status. So I think it comes to about 6 or 8 milligram per kilogram. So you have to use minimum amount for that length of time, because for any invasive candidiasis you need at least that degree of fluconazole. This is for normal creatinine clearance. And I didn't have how long you treat, but generally speaking, after the blood cultures are negative, you treat it for a certain length of time. So usually it's about 2 to 3 weeks. No set rules about it, but generally we tend to treat a little longer. So one of the caveat is Candida enterococcus. Staph has daily bacteremia, most likely, whereas Candida and enterococcus will have intermittent bacteremia or fungemia. So you have to do daily cultures, blood cultures, for at least 72 hours to document that you are truly negative. Otherwise you'll miss it, and then you'll come back to bite us because it has had metastatic seeding. So what about development of aspergillus? You get environmental exposure, including hospital. So it's that now we know that there is plenty of hospital nosocomial aspergillosis available, and this is mostly transplant-based stuff. and then you get infection or dissemination. We won't go too much into aspergillosis. We have, of course, that's a separate talk altogether. But having said that, we have generally when you're suspecting aspergillus in our organ transplant, this one, we go straight to CT. We don't rely on chest X-ray. The reliability is very low. We go straight to a non-contrast CT, and that is good enough. And if you are able to get microbiology and probably a biopsy, tissue invasive disease, that nails the diagnosis. The galactomannan, unfortunately, has been very poor and very confusing, just like beta-D-glucan. We have PCR-based techniques both for sputum cultures and blood-based, this one, but aspergillus rarely is in blood. So it's on tissue. Tissue cultures of PCR still not being validated completely, unfortunately. So if you look at optimal fungal management, if you had ideal testing that becomes positive early in the game, this is for mold infections, you can do either prophylaxis. We do it in the high risk category, which is our organ transplant recipients and bone marrow. Otherwise, we do empiric, just like Candida. And then we do preemptive strategy if you have radiologic evidence without culture-based evidence and stuff like that. And then definitive strategy once you have tissue diagnosis. So that is the general terminology, general management strategy when it comes to invasive mold infections. What are the antibiotics that antifungal agents that we have? And most of the antifungal agents either act on the cell wall or the cell membrane. Polyenes, amphotericin B and fluconazole acts on the cell membrane, whereas the cell wall is where echinocandins act, and caspofungin acts slightly differently, but pretty much they act on the cell wall. What about the mechanism, spectrum of action when it comes to mold infections? When it comes to echinocandins, they are very, very poor agents. They're very, very poor agents. Even though they have some spectrum of activity, they are static. They are not cidal. For Candida, echinocandins are highly cidal. Azoles are static, but candins are highly cidal in Candida and static in mold infections. So we occasionally, to buy time, we surrogately use these medications in our transplant because we have no choice, because we have other reasons, because there's drug interactions, there is side effects, there is this and that, this one, knowing very well that will not succeed too long. So otherwise, pretty much, it's all anecdotal. There's no study data on this. So practically, if you look at current guidelines, which was published recently, there's no data to show that we use this at this point of time for invasive mold infections. Whereas itraconazole, voriconazole, posaconazole, and now izavuconazole carry equal activity against Aspergillus species for practical purposes, Scedosporium and Fusarium species. For zygo, it's either posaconazole or izavuconazole at this point of time. Amphotericin has activity against all generally across all species. Rarely they have additionally trouble. The ampho resist. There are certain candidal species that are naturally ampho resistant, like Candida lusitania is less susceptible to amphotericin. So generally, except for few exceptions, amphotericin can be a workhorse. I'm talking liposomal amphotericin can be a workhorse for a lot of infections. So as you can see, it's pretty much susceptible across the board, and they're all pretty good. And candins are the drug of choice for serious infection, even though they may be Candida albicans. Because pretty much 100% of Candida albicans is fluconazole susceptible. But why do you still use echinocandin? Sometimes is because you want aggressive reducing inoculum, aggressively reduction of because Candida also causes septic shock-like picture because it has endotoxin-like activity. So you want to reduce inoculum aggressively. So that's why we use, early in the game, we use echinocandins for a short period and then move on to azoles appropriately. So what about emerging resistance issues? Unfortunately, Krusei is known to be resistant. Glabrata is already becoming resistant, and there is 10 to 25% resistance, some echinocandin resistance, and parapsilosis has naturally elevated MIC to echinocandin, and there are other species which are intrinsically resistant as well. So for general treatment of candidemias, if you're looking predominantly echinocandin, you can get away with you can get away with high dose fluconazole if we are suspecting Candida albicans as the colonizing agent. You can get away with this one, but generally echinocandins if you're in a severely ill patient. when it comes to invasive mold infections, generally we go with voriconazole at this point of time. What about toxicities and drug interactions briefly? So obviously azoles and amphotericin can have this one, but predominantly it's azoles that cause hepatic toxicity. Renal toxicity, as you very well know, is amphotericin. Rarely voriconazole and cyclodextrin. That's not a major issue pretty much. CNS toxicity, confusion, photopsia with voriconazole is well known. GI toxicity, severe GI insufficiency is known. And this is important. Cardiac toxicity with itraconazole, cardiomyopathy, and then endocrine toxicity. Rarely you can have adrenal insufficiency, because what is the agent that is used for medical adrenalectomy? It's ketoconazole. So voriconazole, posaconazole. So we actually saw patients in ICU, in bone marrow transplant, who are on voriconazole, which is the call was for sepsis. You walk into the room, patient is sitting like this and saying, "Hey doc, how are you?" And stuff like that, and you say, well, it doesn't look like sepsis. The patient looks pretty damn good, but clearly she's hypotensive. So it was adrenal insufficiency from voriconazole. Unusual, but you want to keep that in mind. And rarely there are based on dosing. Rarely you have other side effects with voriconazole, because voriconazole is the only azole for practical purposes has a fluoride ion. I think POSA has it, but vori is the, so with the higher dosing you can get periostitis. You can actually have bone pains or joint pains and stuff like that with a higher dose. So we see that occasionally in our transplant populations. And stuff like that. Clearly, bone marrow suppression with 5-FC. 5-FC we use it obviously as an adjunct with amphotericin for cryptococcal meningitis and stuff like that. So, so their bone marrow suppression is there, and of course other things. Photosensitivity is a significant problem with most azoles, particularly voriconazole, and definitely well known increased incidence of cutaneous malignancy if you use voriconazole for a very long period of time. So those are all well published things. Okay, I want to finish the talk by telling this one. So several years ago when I was in India for a transplant conference, there I go there every year. So they one famous guy, he's an mycologist there, and he presented that on Candidiasis. I said, what are you talking about? You know, we never hear about it. What are you talking about? But now, 2016, CDC and Public Health in New England developed emergence of a multi-drug resistant Candida species called Candidiasis. As the name indicates, they've identified in otitis originally, but now it's there in bloodstream, wound infections, and definitely higher mortality of invasive infections. They've identified in United States now, and originally was first identified in Korea and Japan, now 9 other countries. So it's all over the different continents. So what is the major problem for the lab? Because the major problem for the lab is because it's an unusual organism. It sort of mimics like Candida albicans in terms of testing. And there's another organism called Candida hemolini or Saccharomyces. So now the organism, including testing, whatever testing that we have, you usually will say, oh, it is hemolini. And hemolini is very sensitive. It's like albicans. It's extremely sensitive. So what would we do? We don't do necessarily fungal susceptibilities on every patient at this point of time, but we are moving towards that now. Every bacterium, a fungemic patient gets a fungal susceptibility testing, but generally we advise you call the lab and ask for it, and that is the reason. And there was increased fatalities because failed on fluconazole and amphotericin. So you want to be aware about what the changing epidemiology, and it's here. It's here. So you might see it soon. The lab is looking out for it. The lab is already aware. They are looking out for it at this point. So that's sort of the end of it. Thank you.
Thank you, Dr. Ramesh.